Welcome to your most favorite channel, Heartbeat. My name is Dr. Amrit Kejriwal. This channel is mainly meant for MBBS students, postgraduates, medical professionals, and all those who may find it bit more easy. It is an attempt to make the complicated medical sciences more simplified and easier for understanding.
Today we learn something about electrocardiography, the P wave. Channel's name is Heartbeat. My name is Dr. Amrit Kejriwal. This is the basic waves on the ECG P, Q, R, S, T and again the P. These have been discussed in the previous videos. This is also a common slide. PR segment from the end of the P wave to the beginning of the QRS complex. ST segment from the end of the S wave to the beginning of the T wave. PR interval from the beginning of the P wave to the beginning of the QRS complex, and QT segment interval from the beginning of the Q wave to the end of the T wave. These have been described in detail in the previous videos. Coming to the P wave, the morphology of the P wave in lead 2. It is seen and studied in lead 2. It is pyramidal in shape with a rounded apex. Normal duration is 0.08 to 0.1 second, that it goes up to 2 to 2.5 small squares. Normal amplitude is less than 2 millimeters, less than 2.5 millimeters, that is 2 to 2.5 squares. So we can see over here, this is how the P wave looks normally. Of course, it should have a bit of rounded apex, not possible with computer graphics. In V1, the initial and terminal components are well defined. It is biphasic. Initial component is positive and later component is negative. So in V1 we get a positive component followed by a negative component. We can see the difference between lead 2 and V1. Now the impulse spreads from the SA node to the AV node and simultaneously it goes towards the right atrium and the left atrium. So this is our patient. This is the direction of the wave from the SA node to the AV node. So this is the direction of lead 2. So best studied in lead 2 under normal circumstances. So the normal frontal P wave axis is 45 to 65 degrees and is seen in lead 2. In lead 1, if the P wave is axis at 0 degrees, it will be best studied in lead 1 and it is called left axis deviation. If axis deviated towards 90 degrees, it will be best evaluated in lead AVF and it is called right axis deviation. How to calculate the axis, I will discuss in a subsequent video. Points to be noted. Sinus impulse from the SA node reaches AV node before the whole atrium is activated. With tachycardia, normal P wave gets more aligned with lead 2 and it is always positive in lead 1 and lead 2. Coming to the P wave, right atrial enlargement produces abnormal initial part of P wave. Left atrial enlargement produces abnormal terminal part of P wave. Coming to the right atrial enlargement, best seen in lead 2. With extreme enlargement, right axis deviation may be seen in leads 2, 3 and AVF, that is plus 80 to plus 90 degrees. Total duration of P wave in right atrial enlargement remains unchanged. Amplitude will increase greater than 0.2 millivolts in leads 2 and AVF with right atrial enlargement. In right atrial enlargement, we can see that the P wave increases more than 2.5 millimeters, tall P wave, and in V1, P wave deflection becomes taller, pointed and symmetrical, called as P pulmonale, exceeds 1.5 millimeters. There is a no negative or small negative component seen. In this particular diagram, there is no negative component. The right atrial enlargement may be seen with QRS abnormalities also. we can see a small Q wave over here on V1. So you get a small Q and R wave in lead V1, and decrease in size of QRS deflection in lead V1 with a significant increase in deflection in lead V2. So if this is deflection V1, V2 the deflection will come more. Left atrial enlargement. So we can see it becomes a notched and it's a hump. You can see this hump over here. It's called premitral. Prolongation and delay of the terminal or left atrial component. This first component is due to the right atrium and second component is due to the left atrium. So if the left atrium is enlarged, this component becomes more and larger, and there is a delay of the atrial component, and there is increased posterior deviation of the left atrial vector. Left axis deviation of the mean P wave vector. Coming, there's a notch in the middle of the P wave, P mitral, prolongs the P wave duration greater than 0.12 second. So in right atrial enlargement there is no increase in duration, but in the left atrial enlargement there is an increase in the duration, and in V1 it can be bit more than 0.04 second of the left atrial component. And large left atrial enlargement may cause P wave inversion in leads 2, 3 and AVF. Some patients present with biatrial enlargement, that is a tall peaked P wave, wide and notched, seen mainly in the frontal and left precordial leads. In V1, P wave is taller than the normal and there is a terminal deep wide component. Biatrial enlargement is seen in various conditions such as mitral stenosis with pulmonary hypertension, mitral stenosis with tricuspid regurgitation or tricuspid stenosis, atrial septal defects, and Lutembacher syndromes. Occasionally we do get inverted P waves. They may be normal inverted P waves are normal in V1 and V2 and AVR. You can get an inverted P wave in dextrocardia, and due to improper placement of electrodes we can get inverted P waves. P waves can be seen in retrograde conduction, that is, from AV node the impulse goes towards the SA node, impulse origin or passes retrograde through the AV node. So the bundle of his fibers electrical impulse goes in a retrograde also. So either the origin is from AV node or below, and it goes in a retrograde conduction. Frontal P wave axis in such patients is directed towards -80 to -90 degrees. You get a negative wave in 2, 3 and AVF, as seen over here, leads 2, 3 and AVF, and tall P wave in lead V1. Over here we can see positive. This is due to retrograde conduction of the P wave, either originating from the AV node or passing through the AV node from the ventricles into the atrium. Coming to the P wave left atrial origin. There is a left atrial origin of electrical wave. So from the atrium it goes into the various parts. Negative P wave is seen in leads 2, 3 and AVF, and you get a positive wave in AVR and negative P waves in V4 to V6. These are the left side leads. So if there is a left origin and the V4, V5, V6 are placed laterally, so you get a negative P wave in V4 to V6. A dome and dart wave in V1 may be seen. So this is the isoelectric line, and this is how the P wave looks, dome and dart like appearance. You can see the dome over here and a dart like appearance. So P wave of a left atrial origin in V1 will show a dome and dart like appearance.